One university question, almost 10 marks, but students often mixed up the direct pathway, the indirect pathway, the Parkinson's disease, and the basal ganglia lesions. In the next 5 minutes, I will help you revise the entire basal ganglia chapter using the simple handwritten flowchart and memory tricks. And don't skip the last slide because I will show you one lesion table that can help you answer multiple Viva and theory questions in seconds. So let's begin. First, let's identify the component. Basal ganglia are subcortical nuclear masses coordinating the extrapyramidal system. Remember these anatomical subgroupings. Caudate nucleus plus putamen is striatum. Putamen plus globus pallidus is lentiform nucleus. Also remember that the subthalamic nucleus and substantia nigra as they play crucial role in motor control. Always start your answer by naming these structures with a simple label diagram. Now that we know the hardware, let's understand how these nuclei communicate. Basal ganglia receives inputs mainly from the cerebral cortex through the glutamate, nigrostriate or substantia nigra through dopamine, and thalamus and raphe striate through serotonin. Think of the striatum as the main input station and the globus pallidus as the main output station. Their overall goals are easy to remember. First, start the movement, then stop unwanted movement, and third one is regulate smooth voluntary movements. This simple traffic signal concept makes the functions much easier to recall. Notice how the entire system is designed to produce smooth and controlled movement, not the movement itself. Now the neurotransmitters, excitatory and inhibitory. Excitatory neurotransmitter is glutamate, which produces EPSP by opening sodium and calcium channels, whereas inhibitory neurotransmitter is GABA, which produces IPSP by opening chloride channels. Remember one easy memory trick. Green arrow is glutamate, that is for go, and red arrow is GABA, that is to stop. Remember this throughout the chapter because every basal ganglia pathway is built around these two neurotransmitters. Now let's move to the most important diagram of the entire topic. This diagram alone can fetch several marks. The direct pathway facilitates movement, whereas indirect pathway inhibits the movement. Direct pathway acts through globus pallidus inhibition and thalamus disinhibition, producing more movements. Whereas indirect pathway, subthalamic nucleus excites the globus pallidus internus and thalamus clamp down to halt. Remember, subthalamic nucleus is the key. It clamps down hard on the thalamus. And here, dopamine maintains the balance by stimulating the movement through the direct pathway and reducing excessive inhibition through the indirect pathway. So one line to remember, direct is to drive, indirect is to inhibit. If you understand this balance, Parkinson's disease becomes much easier to understand. And what happens when dopamine disappears? That's exactly what we will see next. Before discussing the disease, quickly revise the functions. Basal ganglia helps in planning the cognitive movements, that is, its discharge start before the movements. It helps in subconscious execution of automatic movements, that is, swinging arms while walking. It controls the muscle tone by gamma motor neurons, so its lesions causes rigidity. And lastly, it also helps in scaling and timing of movements, how fast and how large the movement should be. It is executed through two loops, caudate loop, that is the planner, and putamen loop, that is the executor. They don't initiate the movement. Instead, they fine tune and coordinate it. That's why the lesion produces movement disorders rather than paralysis. Now comes the most frequently asked pathology. Parkinson's disease results from degeneration of dopaminergic neurons in the substantia nigra pars compacta. This decreases dopamine and leaves the acetylcholine relatively overactive. So as a result, there is decreased excitatory drive back to the cortex. So direct pathway becomes weak and indirect pathway becomes dominant. The final outcome is reduced movement, which explains the classical feature of Parkinsonism. In university examination, always mention the physiological basis. Loss of dopamine causes excessive inhibition of movement. Parkinsonism features and treatment. Remember the four cardinal features, that is trap, tremor, rigidity, akinesia, bradykinesia, and postural instability. Remember, the basic cause is decrease in dopamine. So here we give L-DOPA and not the dopamine because dopamine cannot cross the blood-brain barrier whereas L-DOPA can. But along with this, we also give carbidopa. Why? Because carbidopa prevents L-DOPA conversion in the blood, reducing the side effect. So remember, the basic defect is decreased dopamine, but dopamine cannot cross the blood-brain barrier whereas levodopa can cross. Let's see one more comparison that frequently asked in exam. Do not confuse between spasticity and rigidity. Spasticity occurs due to pyramidal tract lesions. It affects only one muscle group. The type is clasp knife type. And the stretch sensitive, that is velocity matters, whereas rigidity is due to basal ganglia lesions. It involves agonist as well as antagonist muscle equally. The type is lead pipe or cogwheel, and it is not a velocity dependent, it is not stretch sensitive. Remember, both are hypertonia, but entirely different mechanisms. This comparison is commonly asked in Viva. When the inhibitory brakes fail, hyperkinetic disorders occur. Remember these associations: Huntington's disease, caudate nucleus degeneration, and chorea. Subthalamic nucleus lesion, hemiballism. Putamen lesion causes athetosis. Think of it this way: too little movement causes Parkinson disease, whereas too much movement causes hyperkinetic disorders. Now, finally, here is the easiest revision table. This is your last minute exam sheet. Substantia nigra produces Parkinson disease. Caudate nucleus lesion produces chorea. Putamen causes athetosis. Subthalamic nucleus lesion produces hemiballism. Accumulation of bilirubin in globus pallidus causes kernicterus, whereas copper accumulation in lenticular nucleus produces Wilson's disease. Spend just 1 minute revising this table before your university exam, and you will remember the lesion correlations with confidence. That's the complete basal ganglia revision in just 5 minutes. If you want the full 10 marks university answer with a detailed diagram and exam writing strategy, watch the main video. And if you want to memorize the direct pathway, indirect pathway, Parkinson disease, and lesion sites using simple flow chart and memory tricks, don't miss the memory video. If this revision helped you, like, share it with your MBBS friends, and subscribe to Physio with New. Remember our formula: learn, revise, and remember. See you in the next physiology revision.